Okay, well, thank you everyone for sitting down for this virtual grand rounds. I don't think this is going to take the full hour. I put this together at John Heckfeld's request, and I was happy to do it because it's been such a crazy time, and just putting this together was a little therapeutic. So I'll be talking today about the blood supply and convalescent plasma for COVID-19. The learning objectives will be to describe the impact of COVID-19 on the blood supply in the US, understand the plan for conserving the blood supply for mHealth, describe the ethical issues that we're going to face if the shortage becomes critical, and then describe the plans for convalescent plasma collection and use. So I'm going to begin with the timeline of how I found out about the COVID virus, because I sit on a committee with the AABB, the Transfusion Transmitted Disease Committee, and there are several senior members of that committee who cut their teeth on the HIV epidemic. And they now dedicate themselves daily to looking at all of the press releases and journals worldwide, looking for potential emerging infectious diseases that could affect the blood supply. And so on January 12th, this WHO bulletin was released that there was evidence that that there was an outbreak in Wuhan in the seafood market, and that they closed the market on January 1, and that currently there is no infection among healthcare workers, no clear evidence of human-to-human transmission, but that there appears to be a novel coronavirus in Wuhan, but nowhere else. So the next day, the AABB and the FDA picked up on this WHO bulletin, and one of the people who look for emerging infectious diseases sent it out to our group and said, I don't think this is going to be the next SARS epidemic, but, and we've been talking to the FDA, and they agree that watchful waiting is the best thing to do. But there's no evidence of person-to-person transmission that was so prominent in early SARS. And the cases stopped accruing after closure of the implicated live market in China, where all the cases to date had direct and apparently fairly intense contact. So January 20th, another email was sent out from the group saying, should we have a meeting to discuss whether there's going to be any implications for the blood industry? And because all other coronaviruses had no bloodborne transmission, it was decided that there was no real concern, so we left it at that. January 22nd, the epidemic in Wuhan had become significant enough that Johns Hopkins launched their map, and you could see that I took a snapshot of this map well into the pandemic, but I began watching this map obsessively from about January 25th onward, every day just watching the red dots growing. January 27th, we decided at AABB that it was important enough to begin screening and deferral of donors. So we made that recommendation that anyone who has been to or through China should be considered for a 28-day deferral. There was no, the FDA did not want a hard and fast rule put in because there was no bloodborne transmission, but that there should be warnings. And we weren't thinking about major health to the donors. We were really thinking about scaring off people because it might be a bloodborne virus, and that could get into the media, and that would cause concern. So we had no general concerns yet that there was a significant problem for donors. I think it was interesting that when I was looking through my emails for this on February 4th, I found this message from the American Red Cross warning the blood industry that there was a shortage of blood. And this is actually a typical message. We get this semi-regularly when there's a dip in donors because schools are out or because there's a hurricane in one part of the country. So no one was worrying about COVID-19. It wasn't called COVID-19 yet, I don't believe. And no one was worrying about it yet in terms of affecting the donors so much that there would be a scarcity of blood. Within 1 month, from February 4th to March 9th, the message started leaking in that the COVID-19, it was still an epidemic, I believe at this point, or pandemic, was going to potentially affect donors to an extent that there would be a problem with blood collections. And so the Red Cross said that they had taken several proactive steps to minimize the impact of COVID-19 on product availability, and that was to reassure everyone that there wouldn't be a severe shortage. March 15th, they began to change their tune, so things were moving rapidly at this point. They said that fear of infection and warnings about social distancing led to 4,600 blood drives being canceled, and that resulted in 143,000 fewer units being collected. Over the next week or two, I began seeing this number increase dramatically. Eventually, I heard it quoted as 6,000 blood drives canceled and over 300,000 fewer units collected. So on March 23rd, they sent out their first real warning that there is a blood shortage and measures need to be taken because they didn't know how bad it was going to get. Now, keep in mind, the Red Cross is about 40% of the blood supply in the US. The other 60% is provided by independent blood centers and small donor centers attached to hospitals. And I wasn't entirely aware of how bad they were at this point. So because American Red Cross is our primary blood supplier, we began to take measures to conserve blood in the hospital. And so we developed a 3-phase plan based on a general warning from the Red Cross as to how bad things were. So the first phase of the plan was going to be when the blood inventory for the Red Cross is roughly 25% lower than what was expected for that time of year. And so by the time this plan was developed, we were already well into phase 1. And phase 1 only involved communication. I posted this message on the Epic dashboard for providers, and this is a new message that I took a screenshot of, but the original message simply said, there's a shortage, it isn't affecting our region yet, but it will come, and we need to take measures, so please be careful when you order blood. I also sent out emails to the heads of all service lines that are heavy blood users and had very, very useful discussions with many of them, and everyone was very responsive to the fact that there was a blood shortage coming. The command center by this time had been formed, and I was in contact with Greg Bielman, with whom I discussed various more critical measures. The second phase of the plan would be put into place when the blood inventory was somewhere around 50% lower than expected. And we're in that zone. So we had the technologists begin to do prospective audits of all blood orders. So every single time someone ordered a unit, the technologists would check the hemoglobin or the platelet count of the patient involved. And if it didn't seem appropriate, they would page me. We always had guidelines in place that the hemoglobin threshold for a transfusion was 7 grams per deciliter, except for hematology oncology patients. That had been 8. We met with the hemonc team and they were agreeable to moving it down to 7. We began to enforce platelet guidelines more strictly, and at this time, outside of us, elective procedures were canceled. Phase 3, which we haven't hit yet for all blood components, although on individual days, we sometimes hit it for group O blood or for platelets. That would be when the blood bank would begin to split most red blood cell and platelet units in half. When you split a unit, of course, it's done in a sterile manner. The daughter bag must be used within 24 hours, but the mother bag of the unit is allowed to remain on the shelf for its full shelf life. It was decided in discussions with Greg Bielman that we would stop massive transfusion protocols at the 6th cooler. So the first cooler that goes out has 2 units of reds, 2 units of plasma, 1 unit of platelet, and then after that it's 4, 4, and 1. So we would be stopping somewhere between 30 and 45 units of blood entirely. there would be warnings put out with each MTP. Whenever the MTP was invoked, I would page the team and warn them that this was happening. And we've only had to do this once. We called the team to warn them, and luckily the MTP stopped at the second cooler. All high blood use procedures will be warned that the blood supply is limited and only X units will be available. That X will shift with each day. In general, Greg Beelman and I decided on 40 units for high blood use procedures such as a liver transplant. And I'll be discussing, I believe later in the talk, how I've worked with the liver transplant team to develop a workflow so that the blood shortage was kept in mind. So this is the daily snapshot that I received from the Red Cross, and this was on March 18th. And the red indicates that they are in a critically low level. So all O's and A's and B's were critically low for red blood cells. Only AB was in good supply. Plasma was in good supply. Platelets were in good supply, which is surprising because platelets are usually where we find a shortage on a day-to-day basis. And pooled cryo was also critically low. It turns out that as blood drives were canceled, committed donors were still going to fixed sites, and it's at fixed sites where more platelets were collected. And so that's why the platelet supply was good nationwide and the red blood cell supply was poor. Naturally, the Red Cross began to adjust their collections so that more red blood cells would be collected at the fixed site. We also get this daily report from the Red Cross, and that is the platelet supply. It simply is the number of platelets we ordered in overnight and the number that have been received. And it's just an indication of how well they're doing with their inventory and other workflow. I asked the Red Cross to begin telling me how their red blood cells and plasma orders were also filled for that day from our local inventory. So it's using this information that I send an email to Fairview every morning saying we're in code green or we're in code red. If it's looking good overall, we're in code green, and that means pretty much things can go as normal, although we're still prospectively auditing, but procedures can go forward, non-elective procedures. And if we're in code red, we start clamping down on everything. So Andy Warhol promised us all 15 minutes of fame, and I got my 15 minutes of fame during this pandemic because I've now been quoted all over the place saying that it's safer to donate a unit of blood than it is to go to the store. I came up with that phrase because I was well aware that it wasn't necessarily safe to donate blood because every time you go out in public, you are risking exposure. Blood centers have taken measures to try and reduce the risk by moving stations for donors apart by 6 feet, by only taking donors by appointment so that people come in and out of the building at a set time, there won't be a group of people waiting in line, and wiping down the entire center frequently to keep it clean. The response to my call and many, many other people's call for blood was very, very good. As you could see, this was a snapshot from March 27th. And since then, we've been mostly green with red blood cells. Sometimes the O's are down in the yellow or amber, and platelets have returned to amber. In fact, today we're quite tight on platelets. Everything was looking pretty good as long as donors would continue to come out until this article came out in the Minneapolis papers. A donor specialist reported that they had COVID and that they may have exposed donors to COVID. As far as I know, the national press has not picked up on this story, which is lucky. But I don't know how things are going other than via the snapshot that we get from the Red Cross. I do know, however, that Memorial Blood Center is looking very, very good. They have plenty of supply and they are secondary suppliers, so we can turn to them if necessary. After the phase 3 response or the three-phased response was developed at our hospital. I worked with many people at the AABB to develop a nationwide phased response. And that was published by the AABB on their website. And then a smaller group of us decided to send it into transfusion for a manuscript. It hasn't been accepted yet. But this group of people expanded our three-phase plan and suggested many other really helpful measures that we will use at our hospital if the supply becomes really critical. So that's just a reminder that the COVID also is a scholarly opportunity for many of us to explore, develop new tests and do new research. This is the response so far throughout the Fairview system. The blue bar is the amount of blood used on February 24th. Throughout the system, there were about 80 units ordered that day. And on March 23rd, there were about 50 units. So we're seeing about a 35% reduction in red blood cells. Platelets, we went from somewhere around 52 to somewhere about 26, so a 50% reduction. And also with plasma and cryo, we're seeing significant reductions. So this is mostly due to the canceling of the elective surgery, but I also think there's a contribution from the fact that providers are now ordering only one unit when in the past they may have ordered two, and everyone's clamping down. So naturally, if we have to move into phase 3, there will be ethical challenges, because we might have 20 units on the shelf available, and we might have orders for 40 units. And so recognizing that, there was an ethical panel that was put together for the Fairview system, asking if the blood supply is critical and orders exceed supply, who should receive a transfusion and who should decide. Other ethical issues was limiting massive transfusion protocols. As I mentioned, Greg Bielman and I already decided to limit it at 6 coolers, but we did that with the back of the envelope sort of thing, looking at the number of massive transfusions we have, looking at the median number of coolers that are used. It's better to have an ethical panel actually looking at the data and considering. And how do we restrict high blood use procedures or limit the blood that's available? Should we allow a high blood use surgery to even move forward, knowing that it might be stopped in the middle? Or should we, should we either stop the high blood use procedures, risking a patient's health, or should we tell the surgeons, you can go forward with the procedure, but we will cut off the supply at 20 units or 30 units of all components that day? So the liver transplant model is a good one for at least one high blood use surgery. This was decided on very early after the COVID crisis began, and it became clear that there might be limitations to the blood supply. It was decided that every time a surgeon receives an order for a cadaveric liver, that they would contact the transfusion MD, and they would try and give us an estimate of the blood use for the procedure. They would also consider the number of units the patient might need after the procedure for a number of days. This, of course, is a very difficult estimate to make, but they're basing it on whether they've had abdominal surgery in the past, what their MELD score is, what their INR is, etc. The transfusion MD takes this number of units that they think they're going to need and contacts the Red Cross and or Memorial and says, we think we need 40 units for this procedure. How much higher can we actually go? And we call back this information to the surgeon, the anesthesiologist, and the hepatologist in a conference call, and they decide together whether this will work out, whether they should go forward with the operation. And I don't. So we've had to invoke this workflow twice. The first time there was confusion. The anesthesiologist was under the impression that we were already in the critical phase, and so canceled the operation before we even had a chance to really discuss it. Although, unfortunately, the Red Cross did have enough blood that day and it could have moved forward. So it was decided that we needed clearer channels of communication. The second time, we gave them a limited number with which to operate, but it was decided to scrub the operation for other reasons concerning the patient. The ethical team also decided that what we should do, and this was adapted from Jeff Cohn's work with Hopkins, that there should be a transfusion triage team put together. And the TTT would review all requests for greater than 1 unit of blood and assign patients a priority score using the intensity of medical need, including the likelihood of a premature death, the likelihood of extremely poor outcomes if they don't receive the blood, the clinical benefit, the likelihood of benefit to the patient, the magnitude of benefit to the patient, and the duration of benefit, the quantity of units needed per procedure and per 24 hours following the procedure, and then whether there are special circumstances such as, is the patient a sickler? Are they pregnant and have a high-risk pregnancy? Whether there's a need for O negative blood versus, say, AB blood or AB plasma, whether they need fresher units, and whether the patient can safely delay transfusion for greater than 24 hours. They made, or we made this score sheet that would allow us to review transfusions and try and decide based on the scores who gets the blood and who doesn't. Ethically, this is probably as good as we're going to do. Logistically and feasibly, this is going to be incredibly difficult because blood orders do not come in an orderly fashion where we can sit down and compare 10 different blood orders at the same time and decide that 6 people get the blood and 4 do not based on inventory. They trickle in throughout the day, and so the TTT will have to have a sense of historically how urgent blood need is for a patient like this versus what might come in during the day. So the ethical group was really committed to the idea that we were not going to work with a first come, first serve model. But unfortunately, there, I think, will be aspects of first come, first serve because we might end up allocating most of the blood and then another case will come in later in the day that we cannot fill. All of us hope that this doesn't happen. After this grand round, I'll be presenting this ethical framework to the command center. They've been looking at it and they'll decide how it's going to be, whether it's going to be used and how it will be used. The ethical group and the command center will also decide which doctors are on the TTT. They want a transfusion MD or a hematologist to present the patient to the committee, and then the committee, composed of someone from risk, an ethicist, and maybe 1 or 2 clinical doctors will then decide how the patient fits into this framework and whether they receive blood or not. Of course, because orders trickle in throughout the day, the TTT will have to be on call 24/7 and available immediately when a blood order comes in. So I'm done with the first 3 parts of my talk. The last part is the ray of hope, and that is convalescent plasma. Convalescent plasma has been used throughout the 20th century for several diseases, polio, measles, mumps, and influenza. And a meta-analysis of about 1,700 cases of Spanish flu found that there was some efficacy. There was reduced mortality when convalescent plasma, or CP, was used. But the efficacy of CP varies with the disease and with the application of CP. In more modern times, it's often been used as a therapy of last resort, and that's because it's very difficult to say how efficacious it is. One needs to be quite strict with a randomized controlled trial to find out what titer one needs to use. Of course, you can measure neutralizing antibodies, but every donor is going to be donating a different level of titer, a different level of neutralizing antibody. What timing should you use? Early in the disease, late in the disease? It's all the papers I read about convalescent plasma suggest that one should use it earlier in the disease, when the level of virus is lower in the patient and the antibodies have a greater chance to have an effect. That's the sort of simple mechanism for how this works, but there are other mechanisms at work in terms of inflammation. Sometimes that inflammation works against patients. There are cases where convalescent plasma made things worse for patients. That's when they use convalescent plasma also with monoclonal antibodies against the disease. But in the 2009 H1N1 pandemic, convalescent plasma was shown to reduce mortality, and in Ebola, it was used in a limited capacity, but it showed significantly longer survival for some patients. When convalescent plasma has been used strictly with coronaviruses, in the SARS epidemic in 2003, there were 80 patients in Hong Kong who were treated with convalescent plasma. And those who were treated before 14 days after they were thought to be infected, it showed improved prognosis with earlier discharge from the hospital. And they found that patients who were PCR positive but seronegative for the coronavirus at the time of treatment did relatively better. A study of 99 recovered SARS patients, they found that 87 out of 99 had neutralizing antibody, although they didn't say in the article anything about the titer. During the MERS epidemic, there were just, in the literature, I found 3 patients who had been treated. Only 2 of those had neutralizing antibody detected in their serum. There has been one study published with COVID-19 and convalescent plasma. Probably everyone is aware of this study. It was a case series with 5 critically ill patients. They all had ARDS, and they were administered 400 mils of convalescent plasma. That convalescent plasma had an IgG titer of 1 in 1,000 or greater than 1 in 1,000 and a neutralizing titer greater than 40. They administered convalescent plasma within 10 to 22 days after admission, and all patients improved within 1 week after treatment. Naturally, this was not a controlled study, so I don't know how much one can take away from this, but until we have a vaccine or a drug that works, this appears to be the only option that can be used. Currently, there are 3 major protocols that are that the FDA is considering for approval. One is for prophylactic use of convalescent plasma. One is for use with mild to moderately ill patients, and the primary endpoint of that protocol will be whether the patient ends up in the ICU or on a ventilator, and of course there are many other secondary endpoints. And then the third protocol is for severely ill patients. Although there's been some discussion amongst local people throughout the metro area of writing our own protocol, we're also strongly considering just signing on with the mild to moderate protocol. One of the really important reasons to sign on for a protocol is, A, we would then be feeding our convalescent patients into blood centers so that they can be collected. And the second is that is currently the major way to gain access to convalescent plasma is if you have an IND and a study going. The FDA does have an emergency IND for single patients, but that will become a cumbersome sort of pathway if we have over 1,000 patients in the state at any one time. So the FDA has laid out these guidelines for collecting convalescent plasma. It's a moving target. It changes. It's been changing on a day-by-day basis as various groups have been discussing things. But as of today, patients must have a confirmed COVID-19 diagnosis. They must be 14 days post-recovery, and there is a definition for what that means. and they must have a negative nasopharyngeal swab. Or they must be 28 days post-recovery of symptoms with no nasopharyngeal swab. One of the reasons why this was put into place, or two reasons. One is, of course, the longer you wait, the higher the titer of antibody. And the second is, there are some places that are running out of nasopharyngeal swabs. And then there's also, in Seattle, the workers currently refuse to take nasopharyngeal swabs of COVID-positive patients. So, at least many workers, from what I've heard on phone calls. According to the protocol, you should then draw a tube to obtain titer from that recovered patient, but that is no longer considered absolutely essential from the hospital end. It is hoped that the blood centers will do that, and that all of this information can be linked together in a study. The patient must bring a copy of a sign sheet from a doctor saying that they've had COVID, that they've recovered for 28 days at least, or 14 days with a negative nasopharyngeal swab. And there still are trolley mitigation steps that are in place for these donations because they're considered standard plasma. So you must be male or nulliparous female, or a female with no HLA antibodies to donate convalescent plasma. It has been randomly decided that a dose is 200 mils. So the study that we are thinking of signing on for is saying that all patients should receive 2 doses. This is what I've gone through already, that there are a number of protocols out there for obtaining the convalescent plasma. One thing I didn't mention is that the FDA is trying to put together an expanded Access IND for sites that are not academic and can't stage a study. There's a lot of anger on phone calls with groups across the nation because these protocols are largely circular. If you're in the protocol, you're sending the donors in to donate, and only the people who do that receive the convalescent plasma. And of course, that is not fair. That is not necessarily ethical. And also, as I mentioned, we're in discussions with HCMC, now North Memorial as well, to do our IND together so that everyone can benefit. And it's presumed that the blood will be collected at Memorial and the Red Cross. The Red Cross has chosen to pathogen reduce all of their plasma, so it will be significantly more expensive, but we will just go with whatever place the donor feels more comfortable going to. And I've already also discussed that there are ethical implications for who gets convalescent plasma and who doesn't. Of course, it isn't even a proven therapy, so this is like any trial. And that is it for my talk. Thank you for taking the time today, and I'm open to questions.
Claudia.
John.
That was a fantastic presentation. Thank you so much.
Thank you.
I actually have 2 comments and 1 question.
Okay.
Number 1, eventually there probably will be some shortages of plasma, and I would suggest that you switch your massive transfusion protocol to make it a 2-to-1 rather than a 1-to-1 ratio of red cells to plasma.
Mm-hmm. That's reasonable, John. Yeah.
Yeah, that will definitely help you save plasma. The other comment is that there really are now electrical ways or computer ways for you to do the audits in the blood bank rather than having to have the technologists do audit for each transfusion. And of course, this is not in place at Fairview, but there are computer ways and informatics ways to do this, and that may, down the line, that may be something you might want to look at.
I'm Thank you. Before your question, I'm painfully aware of that because I've tried to get some of these IT algorithms in place,
Yeah,
and haven't been successful yet.
It's a shame that you don't have that, because since you're having to do these audits up front, that takes a huge amount of the technologist's time to audit for each order, and that shouldn't be necessary anymore. There are very good ways to do the auditing from an informatics point of view, and so this should not require people to be involved.
Well, as Rahm Emanuel said, never let a good crisis go to waste.
Yeah, right.
I hope that that we'll be able to get some measures in place following this based on some of our experiences. But you also had a question.
Yeah, I do. The question I have is, does anybody have any idea yet what the epitope is on the virus that the convalescent plasma antibodies are reacting to? Has that been worked out yet?
I don't know the answer, but there might be people on the line who do.
I see Chris is there.
Yeah, this is Chris. That's not known for convalescent plasma because there's not enough experience with it yet. But just from developing the ELISAs and looking at neutralizing antibodies, it seems that antibodies to the coronavirus spike protein receptor binding domain are effective, but it appears that there's some efficacy of antibodies to two other spike proteins as well.
Oh, really? Okay. So there might be 3 different epitopes.
Alert from AOS Alert Manager.
Is that right?
This Mac can't connect to iCloud because of a problem.
That's right, Jim. Claudia, can you clarify for me, is the fact that, so you're not going to measure the titer in the convalescent plasma?
We're going to try, Chris. I think that we're going to be able to get a workflow going that we can draw plasma from a patient at 28 days before they head to the blood center, because it seems to me that that would be a huge thing to miss for something like this.
I completely agree. So are you working with Mark on that, who's developing an ELISA here?
I haven't approached him yet, but I'm planning on it. I'm first making sure that I've been just yesterday I began talking to Leo about getting money for this study, and I assume we're going to get it. I've heard that BARDA might make funds available for these studies, for some of these studies, or for pieces of the study. But yes, we absolutely need to do that.
Maybe I could chime in. This is Leo. Claudia, I think the other person to weave into this is Amy Carger, because she's working closely with Mark. And, as soon as the, if you will, developmental aspects are finished in Mark's operation, the intent that he has with Amy is to move the serologic test over to ARTL. So I think if we were to get into this, she would be most helpful.
I'll do that. Thank you.